Something like
Is prostate cancer the most common, or is it colon?
Well, we do a lot of prostate cancers. So we've done several clinical trials in prostate cancer. Our results are really good. So that kind of makes us very popular for prostate because our success rate is really high. We do lots of other cancers, as well, but definitely prostate's probably our number one. Pancreatic is probably number two. Of course, we do plenty of breast. We do, colorectals. We do sarcomas. We do a lot of different solid cancers. I mean, we can do, ovarian, endometrial, pretty much all the solid cancers we can do. But yeah, I'd say our biggest ones are certainly prostate and pancreas. Probably after that's probably colorectal. And we do lung, do cancers of the liver.
Does the success rate vary depending?
Vary. So you have certain cancers that are very more immune sensitive, so they're easier. So prostate's one that we found we have a pretty good regimen for, and then pancreas, we have a pretty good regimen for it. Sarcomas are more challenging. Those are probably of the overall cancer types. I mean, there's lots of types of sarcomas. Some are okay, some are really hard. That one I think is the most challenging to treat. We do have regimens to treat it. It's just a little different. And it depends on the patient's state. Like, if you catch a patient early, much easier. If you get a patient that's late, that's advanced, well, that's much harder. Not to say we can't turn it around, but the amount of tumor volume is certainly a big indicator of like how successful. So some patients come to us and they have a lot of cancer. We're like, oh gosh, we don't know if we can fix this, so it's too much. So it's nice if the patients come to us before they get really, really bad, because a lot of those we just can't help. And we don't want to take them on and not do well for them. Our main thing is we want to treat people that we know we can help. And if we have the thought that we can't help that patient, it's better for both, for the patient not waste their time, right, and money, and for us not to waste our efforts as well, which is difficult because you want to give everybody the opportunity. You want to try to help everybody, but sometimes it's just not appropriate. So it's a hard decision, and sometimes the patients they want to try anyway, and I understand that. And sometimes we'll say, okay, we'll give it a shot. We never know. There are patients that you would think would be completely hopeless that we've been able to save. So it does happen, but we definitely love to cut patients like earlier. I mean, really, the best thing would be as soon as a person potentially knows they have cancer, even before the biopsy, if they came to us, and we could biopsy, we could treat it. That's the best way. But clearly, a lot of patients don't know about us until what happens is patients they end up with doing the standard treatments, right? And they assume that might work, and maybe for early cancers it works, right? But for later cancers it doesn't work. And so once the regular treatments fail, and then the person starts saying, oh gosh, okay, this is not working, then they start looking at their other options, and then they find us at that point. So they're a little bit later. So it'd be ideal if they could come to us up front.